I'm Kazi. I'm a cardiologist at San Francisco General and a health systems researcher here at UCSF. We know that this event is organized under the leadership of Jim Kahn, who's the director of GHEcon, Global Health Economics Consortium, as we like to call it, GHEcon. Doug Owens, who's the director of the Center for Health Policy and Center for Primary Care and Outcomes Research at Stanford. We named the street after him. And Dean Steph Bertosi from the UC School of Public Health. So thank you very much.
We have a fairly large community of people doing global health at Stanford, distributed in a lot of different centers. As Kazi said, I direct the Center for Health Policy, which is part of the Friedman Spogli Institute for International Studies. And there are scholars throughout the university who are interested in global health and health more generally. And so we'd love to have any of you down. We look forward to collaborations, and we're going to learn a lot here today. And Jim, thanks very much.
It's great to be here. I'm sorry that Will Dow, who's a partner in crime on this, who's taking a sabbatical in Tokyo, can't be here with us. I see my role as being, in large way, the connector, the matchmaker. And I would very much like to help make matches between activities at Berkeley, activities here, and activities at Stanford. So if I can be of help, please don't hesitate.
Kazi and Jim asked me to talk a little bit about kind of a case study of where economic analyses helped inform policy questions. So right now, you see, we have guidelines from a number of major groups. And prior to September 2006, the CDC recommended that people assess risk behaviors and screen high-risk individuals. In and around 2005, about a quarter of people who had HIV were unaware. So based on those, you certainly get the picture that what was happening at the time in terms of diagnosing HIV was inadequate. It really wasn't getting people identified early in their course of disease. So what I'm going to talk about, what they asked me to talk about, is sort of this case study, or two studies, one that we were involved in. These were cost effectiveness of screening. This is the first, Jillian Saunders and other colleagues who you may know that I was involved in. And then another analysis done by David Paltiel and his colleagues at Yale and Harvard. But I think the most important result was the following. But what we show here is the cost effectiveness. This is with transmission included. This is if you exclude transmission benefits. It's clear, crystal clear now, although it wasn't as much at the time, that antiretroviral therapy prevents transmission. So take a look at this dotted line. And then if we just pick this $50,000 per quality line, we can look down and see what the prevalence is at which screening is cost effective. And that turned out to be 0.05%. Much, much lower than the CDC's threshold at the time. Our friends David Paltiel and colleagues from Yale and Harvard got a very similar result, and their analysis suggested that screening was cost-effective down to a prevalence of about 0.1%. The take-home from this here, though, is that screening was cost-effective at least at a prevalence 10 times lower than the CDC's threshold at the time. So to summarize, including transmission, screening was cost-effective down to much lower prevalences than were recognized in the guidelines at the time. And we had done some work on the seroprevalence of HIV in healthcare settings. And back then, this suggested really that screening is cost-effective in virtually every healthcare setting. The main point that we made to them is if you're going to have a threshold for routine screening, the one that you have now, 1%, is far too high, certainly in terms of cost effectiveness. So then what happened? The CDC released their guidelines in 2006, and here's the change. So it says the CDC recommends that diagnostic HIV testing and opt-out HIV screening be part of routine clinical care in all healthcare settings in an opt-out way. In all healthcare settings, screening for HIV should be performed routinely for all patients 13 to 64. Providers should initiate screening unless the prevalence of undiagnosed HIV has been documented to be less than 0.1%. That threshold that they chose came quite directly from the cost-effectiveness analyses that David Paul-Till and his group did and the folks that I was working with did. So just to summarize, I think this was a situation where there were cost-effectiveness analyses, economic analyses that had come out at an opportune time because many guidelines were being reconsidered for other reasons. And the analyses suggest that there were substantial benefits to the HIV, the person with HIV, that there are also advantages to the community in terms of reduced transmission. And the thresholds at which routine screening is cost-effective were far, far lower than the guidelines at the time. And this has now made its way into policy statements from the CDC, the Task Force, the ACP, the American Academy of Pediatrics, the VA. There are probably other groups now. And we now have a fairly broad consensus about HIV screening in the United States, which I think has helped move that forward to some degree.
I want to turn to our panelists, and I'm going to start with Elliot, because Doug set it up perfectly. He put up a 50, 100, 150. And I'm curious, Elliot, I think that you probably have some issues with that approach. So why don't you share those with us?
Where you would get that idea from, Steph? It's really nice to be able to think about the interpretation of your incremental cost-effectiveness ratio and what it means in terms of does this indicate cost effectiveness or not, because all you have to do is look up the per capita GDP of the relevant country, and if the ICER, if the cost per DALY averted is less than 1 time per capita GDP, it's cost effective, and if it's less than 3 times per capita GDP, it's very cost effective. You don't need to think about it any further. You don't need to think about the budgets or resource constraints of that country, because there's been this widely adopted standard promulgated by WHO Choice originally that established those thresholds as what should be meant by cost effectiveness. And I and others became increasingly uncomfortable with this for a variety of reasons, and published a paper about a year ago in the WHO Bulletin, which I want to acknowledge them for having published it, because it was a pretty polemical piece describing the shortcomings of the WHO threshold. One is, if you liked thresholds, and there are problems with thresholds that are divorced from budgets, but if you like thresholds, this particular one is too high. It is almost impossible to rule anything out. Another difficulty is that it doesn't distinguish, or it encourages analysts and decision makers not to distinguish between cost effectiveness ratios that meet the threshold. In other words, you could have, $10 per DALY averted for intervention A and $100 per DALY averted for intervention B. That's an order of magnitude less efficient. B is 10 times less efficient than A. But if both are under the threshold, they're both cost effective, and the implication is they should both be implemented. And WHO's response to this criticism, and it's not just mine, they're hearing this from different quarters and they're doing their own thinking about it, is that this was never intended to be meant as a decision-making criterion. I think it would have been nice if they had mentioned that a little earlier.
Do say something more about the cross-sectoral implications. And do you see, is this opportunity cost issue that we just touched on, does that change at all if we're talking to the Minister of Finance rather than the Minister of Health? Absolutely,
and in poor countries, it's really more, practically it's more a multi-criteria decision analysis issue, and cost effectiveness is a very small piece of that. People are making decisions at the Ministry of Health, and cost effectiveness isn't in the mix. There's more politics. So for example, in Uganda, where I happen to know some of the high-level policymakers, they're pushing a program of community-level health workers who are very costly. But in a time of political sensitivity, they are very politically valuable. So it's $20 million to pay them on an annual basis. It's clearly not cost effective on the back of an envelope, but they're spending money in that direction. But going back to the cross-sectoral comparison bit, I think that's really the main value of the cost-benefit framework. But we've just heard that you can switch very quickly from cost-effectiveness to cost-benefit by using a threshold and monetizing benefits. That's another small point, and I'll invite people to add to the advantages and disadvantages, is the idea that you don't need a comparator if you use cost-benefit. You can use it as a standalone if you ignore deadweight loss from taxation, but then you still have the fiscal constraint problem. Even if you have intrinsic value of a single intervention, where if benefits exceed the cost, then you should implement, you still run into the constraint of your budget. So I think that we're in a field of many bad choices, but for very important work. We have to do this work.
I'm going to ask a slightly provocative question. Given the challenges in the health sector, in the expertise around economic analyses, and the relative wealth of that capacity in the financial sector, in the ministries of finance, should we be doing cost-benefit analyses which focus much more on monetizing everything and presenting our results to the people who not only understand these analyses, but who control the purse strings to a great degree, that is ministers of finance? Should we bypass our colleagues in ministries of health and go directly to the ministries of finance?
Yes, absolutely, absolutely. Insofar as you can monetize health benefits, whether it's imperfect, because QALYs are imperfect.
We don't yet have answers to all of these. I just wanted to add a follow-up to the last question, where I think a very interesting application of this question about unborn kids is going to come up in the context of the Zika virus, where people are being told to delay childbirth for 2 years. But clearly these are all issues that I think we just all need to keep working on and coming up with other solutions. And to me, bringing considerations other than just economic efficiency is really important. So looking at distribution, looking at equity, these are things that economists don't necessarily have the answers to, but I think we can't ignore them. So.
No, I won't go into anything more substantive, but I would like to end with a call to those of us who do work in poor countries, and I really emphasize the word poor because that's what they are. I think there's an onus on us to increase capacity. There's a standards issue. We have standards, but they aren't always used. And insofar as we want to improve decisions at the policy level in poor countries, I think there's an onus on us to work into our projects and our grants, local capacity building, and then sort of build a community outside of this room of people who think about these issues, think about efficiency and health outcomes.
Well, I want to thank my exceptional panelists and the exceptional questions and comments from the audience. Thanks to everybody.
Delighted to have Mark Sculfer here from the University of York. Without further ado, Mark, thank you for joining us.
It really is a great pleasure to be here. I'm so glad to have been invited. Let's start off with something quite general about NICE. It was introduced in 1999, and what I'm going to focus on is technology appraisal. That is NICE's role in issuing guidance to the NHS about the funding of mainly new branded prescription pharmaceuticals. An important thing to recognise about the technology appraisal programme, the drug programme if you like, is that there is a financial mandate. So if NICE says this is cost effective and it should be used, the NHS has to find the money for it. The threshold, or NICE's decisions, have been to recommend technologies at a higher cost effectiveness ratio over time. So they've been pushing up and up. And in part, that's because of a really important discovery, which is that the term threshold is used to mean all kinds of different things. Perhaps this is, we should have realized this years ago. The way we think about, and doing the work I've just described, have been thinking about the term threshold, is as a measure of opportunity cost, the supply side concept we've been talking about today. When NICE think of the term threshold, they think, yeah, it's partly about opportunity cost, but it's partly about the value of things other than QALYs that they want to reflect in decisions. This is what we thought might be the answer. This is what we've been trying to push NICE to do. We're still doing it. I'm not particularly confident. And it's what we think would be a social perspective, societal perspective, MCDA. That is that we present a balance sheet. It's an impact inventory, in a sense, to the committees at NICE, and they can make their decisions. So here, just an example. This is Lucentis, diabetic macular edema. Needn't worry too much about the details. But basically, the cost per QALY is about £25,000. There was 23,000 eligible patients. So what we could show, firstly, to the decision makers is, well, this drug doesn't have a mortality effect, therefore doesn't generate life year benefits. But because it costs the system £80 million more per year than current practice, it will sure as hell have opportunity costs in terms of deaths and life years for other patients in the system. And we can express that in terms of QALYs as well. So in net terms, at a cost per QALY of 25,000 and an estimated opportunity cost at the margin of £13,000 per QALY, as I showed you earlier, this would have a net detrimental effect on population health. However, well, the burden of diabetic macular edema is somewhat more than the average burden associated with the disease for which treatments are displaced. Perhaps more interestingly, though, we get productivity benefits of a net positive effect on productivity of about 85 million from Lucentis. And we only forego about 50 million. So there is a net productivity benefit here. So we've got a very stark trade-off. In funding this, we actually have a negative impact on population health, but there is a net effect on productivity, a net positive effect on productivity. So ultimately, from a multiple perspectives, multiple criteria viewpoint, the trade-offs are quite stark for the decision-making body. So they could just take, as they would currently do, a health and healthcare perspective, which would indicate, why would we fund this technology? It reduces population health by about 3,000 QALYs. But we could equally take a view which we're not interested in health at all. And this is the sort of naive cost-benefit analysis approach, not the CBA approach we were talking about earlier, but this is how it's been operationalized in some settings in the past. That is, we actually get a positive effect. It costs 80 million, we get 85.2 million pounds worth of net productivity gains. So basically, we have a reduction in net societal costs, if you like, of about 5 million. But that sort of societal perspective fails to take into consideration the fact that there's a budget constraint. So we could have a societal perspective which accounted for the opportunity costs in terms of health. So we've got a net loss of 3,000 QALYs. We've got a wider social benefits of 85 million. So in that context, we could say, all right, we're losing QALYs, but we're getting productivity. So as long as a society, our willingness to pay, if you like, our consumption value of a QALY is less than about £29,000, then we would fund that. That's the sort of trade-off. But even that's wrong because it fails to reflect the production opportunity costs associated with a fixed budget. So in reality, that loss of 3,000 QALYs has to be set alongside not the 85 million, but about 35 million once you allow for the opportunity costs on productivity. Now then, we would fund this technology if our consumption value of health, our willingness to pay for health, was less than about £12,000. That is the type of framework we would need to move to, we would argue, if we bring in multiple perspectives and multiple criteria. Thank you.
I'm delighted to introduce the panelists, but I'll start with the moderators. The panel is going to be moderated by Carol Levin, who is Associate Professor at the University of Washington.
So we want to talk a little bit about health disparities and how when we think about evaluating interventions and the cost effectiveness of interventions, how the considerations about health disparities can play a role. If we assume that an intervention works the same way in a population and you shift now as a result of the intervention, those groups at highest risk at the tails, the difference between the tails don't shift, right? So the mean in the population has improved, but the impact on disparities is completely unchanged. And this, I think, is probably what's most commonly seen in many types of healthcare interventions. So everyone's health's improved, disparities remain the same. What Froelich and Popkin argued, though, is that what actually happens is that disparities often worsen in the face of healthcare interventions. And that's because there is variability in the uptake, the impact of the intervention. And whereas one might see the same shift in the mean in the population, there are going to be groups that have concentrated risk as well as groups that have concentrated benefits, and the gap between those is actually wider than at the start of the intervention. And the point to make here, so disparities worsen, the point to make here, and if I could leave you with anything, is that if we believe as a society we want to address disparities, it is not enough to say that improving the health of a population will have an impact on disparities, because there's plenty of both theoretical and actual evidence that this is likely not the case. So the things I'd like to leave you with, so the beneficial effects of health interventions on disparities can't be assumed. That's probably the most important things. Interventions may actually worsen disparities. Designing and evaluating the impact of interventions must consider multiple factors. I've just listed some here. There are many more to consider.
Thank you, and thank you for letting me be a part of this panel. Today I'm going to talk a little bit about a novel framework for examining questions of budget impact and affordability. To say how much budget impact was potentially too much, we had to come up with some sort of a threshold. So we're really looking at how much of a net cost increase could we have for a new intervention before it would contribute to growth in overall healthcare spending that's greater than the anticipated growth in national GDP plus 1%. We chose the national GDP plus 1% based on some policy considerations that are out there. Massachusetts and Maryland both have used similar types of benchmarks. We're looking at the potential budget impact for an individual drug, and if it contributes significantly to cost growth above this threshold, then we think that should serve as an alarm bell for greater scrutiny and for efforts to maximize health system value, perhaps through management techniques such as prior authorization or other things. So in summary, there's several value frameworks that are out there that have been created recently, looking at the prices of new high-impact drugs and devices. We think there's a need for this because there seems to be a disconnect from at least perceptions of value out there. We think that very high potential budget impacts must be managed to sustain healthcare systems regardless of cost effectiveness and efficiency. That's something that needs to be integrated into our decisions around value. And that explicit consideration of health system budgets and affordability should now be part of that value conversation.
Hello, thank you for the space that you kindly have given me to be today with you in this important colloquium. We are a society that are evolving. We are growing older. We are aging. And if we do not make ourselves sure that we grow older, taking care of ourselves, preserving in smart and healthy lifestyles, we will end up as the most expensive, endangered generation in the history of mankind. Physicians, scientists in the field of health would not be able to confront this challenge just by themselves. We need a cross-cutting approach. We need the entire society. We need governments, society, NGOs, companies, private sector, private along with public sector and international organizations working together in order to find those public policies that could enable us to construct a new generation of citizens of the world who could be healthier, more productive, and happier. Thank you so much.
Thanks very much indeed for the invitation. But this is touching upon a little bit the MCDA, the multi-criteria decision analysis, which is we give another figure of merit in this context per budget or dollars spent for within the health sector to think about things and resource allocation. So basically, same kind of thing per dollar spent, health benefits, poverty reduction benefits. What we have within the health sector is that we have two figures of merit, which basically the policymaker, when designing a health benefits package, can also consider how including specific interventions through, say, public finance can prevent impoverishment related to the payment of medical care for certain conditions. What we've been doing in basically a lot of resource allocation within the health sector is really focusing on the right-hand side here, identifying the best buys in dollar per quality gain, dollar per daily averted, and so on. So now, even within the health sector, we should think more about what is, the sort of risk premiums that we buy or the insurance value that we buy by investing in specific policies. So that's one dimension which is within the health sector. The second, probably much more important, is that we can use this, and it's very, relevant in the context of, development and economic development and the SDG, is that this is very relevant for priority setting without, priority setting beyond the health sector, or basically on a basic package of, say, vaccines or so on. I can, look at the return on impoverishment that I'm getting, and I can make explicit comparison, which happen all the time at the Ministry of Finance level. Who is the person who holds, at the end of the day, the decisions and the dollar allocation, is you can basically make these comparisons for what is the return in terms of development for these countries and in terms of poverty reduction with other things like, say, transport or other development agendas.
I think what I'd like to do is open it up to the audience for questions.
Does your algorithm take into account the person who has to care for the patient with the problem? So the kind of that person who's left out of the socioeconomic infrastructure to care for the trauma patient or the patient with the disease. Yeah, the caretaker and the loss of income to the caretaker. And a question for Rick, does your algorithm identify the costs for drugs that's allocated for the marketing of the drug and the packaging of all the drugs? It's more in the United States an issue, but there's a huge cost that's passed down to the system, and I'm just curious if that's taken into consideration.
So the answer is no, we're not in this thing we've seen, but we're basically working on including that in the next iterations.
And then in terms of the marketing cost, we're not explicitly considering those separately, but to the extent that those are included in the list price of drugs, it would come into the equation.
Thanks so much. So I'm going to take a very short period of time to just get even broader than where we have been before. So everybody knows what universal health coverage is, but it's basically a very aspirational goal as it's stated by the WHO, which is all people can access the health services they need without incurring financial hardship. And if you look at, how to get to universal health coverage, you can really take one path toward financial protection, in which case you'll emphasize hospitalization, catastrophic spending, et cetera, or you can take another path and emphasize primary care, public health, and that will emphasize health status. The truth is that it's a long and winding road. This is the traditional dimensions of universal health coverage. This is called the WHO cube. the infamous WHO cube. And the idea is that you start to fill up this box. But if I look at what Europe did, it started basically with hospital care, and then it grew. And it grew to encompass the rich and the poor, and then later on primary care. And then gradually, as other services became available, these were added to the mix. So a country, typical low-income country in Africa or India, starting in this particular way, has a lot of options. Dizzying array of options. And it's a challenge. It's a real challenge, not only for policymakers, but for us as advisors to policymakers on which direction should they go. And every agency that goes in to advise a country probably advises a slightly different or maybe radically different approach and direction. And this is exactly the challenge that we are giving low-income countries and policymakers. Thank you.
And I want to start by just pointing out that the current world record for solving the Rubik's Cube is 5 seconds. So in the time it took me to say that sentence, we could resolve that problem that was posed there.
Why haven't we brought in more behavioral economists, more political economy analyses, all this sort of stuff? Why hasn't that happened yet? What can you do about it? And the second stage is, why haven't we included public economics in this? We're all talking about these questions from the perspective of this is the money we have to deal with, but why doesn't this community talk about how do you increase the size of that pie?
I mean, I think there is a big role to be played by both public economists and behavioral economists. And for example, oftentimes you can say earmark tobacco taxation or sin taxes to provide revenues. I know that one of the biggest success stories recently is the Philippines, which increased the tobacco taxes in late 2012, and they allocated 80% of the revenues to universal health reform, universal health coverage. And that was the big reason why it was able to get passed, is because that was on the agenda. That the president didn't really care about the taxes per se, but cared about tax reform more broadly and about universal health coverage. And so I think that there is a lot of opportunities there. And then, I think the behavioral economic side is more, at this point, on the interventions in terms of coming up with more effective interventions. And I think that that's less the emphasis in terms of the discussions here today about valuing health. And so I imagine that's why that hasn't come up more often.
Is there any very important ethical concern about measurements in cost-effectiveness analysis? Because we measure many things that cannot be quantified in a traditional sense.
Well, I think the ethical point was that if you're going to use resources in a way that does not maximize the number of deaths averted from the resources you have, then you are paying for whatever you're paying for your human rights objectives with dead people who don't need to be dead.
I just wanted to comment that the new book on guidelines for cost effectiveness is going to have an entire chapter on ethical questions and cost effectiveness analysis, which is a new addition since the original.
I took extensive notes throughout the day, and I was going to summarize the day's events. It turns out I can't actually read my handwriting, and so this is going to be shorter than I'd initially planned. We've had a lot of fun, engaging conversations today, and a quote comes to mind, and it's the English statistician George Box when he said, "All models are wrong, some are useful." We've gone back and forth on the limitations of this process of addressing efficiency versus equity. Are they truly dichotomous goals? Are they synergistic goals? But there are a few things that jump out. Kirsten reminded us that if we truly care about reducing disparities, then moving the mean health of the population is not enough, and we'll have to invest in in that. I loved Elliot's comment that maybe just thinking about thresholds all the time has set us back because they're such a blunt instrument without much of an empirical basis for how we use them. I loved Mark's talk. He did say that, actually reducing heart attacks may increase costs to society, and I was afraid for my job briefly, but the fact that thinking about this in terms of opportunity costs, and the words he used is bringing alive the hidden patient, that when we're making these investment decisions, we're taking these dollars away from someone else's health, whether it is to address equity-related issues or just a sexy new technology. It is, someone else is paying for it. I would, I could go on and on, but there was Neelam's comment saying we focus too much on value in health, and maybe thinking about values in health is another way of tying together this contrast between equity and efficiency. A comment that Mark made that stuck with me is that so much is lost in the terminology, and maybe we need to bring people together in platforms such as this, where we can have a more nuanced discussion about how we can improve healthcare without trading the size of government off against, healthcare equity and reduction in disparities. We should get other experts here, political economists, actuaries, cardiologists, whatever it takes. But I realize that there are a lot of unanswered questions here, but I come away from this day of conversations feeling like there are a few windows in my brain that have opened up that I didn't know existed, and I would hope that at least some of you had a similar experience. So thank you very much. A big round of applause for GHEcon and Devin, who made this possible. And it is time for drinks.
And a huge round of applause for Kazi.